Welcome to the RCI GDAS webinar, Mental Health and the Older Adult, the Assessment. Presented by today's speakers, Joshua Lynn Chen, and she will be assisted by Kathy Rambach. They are from the Fuqua Center in Atlanta. Before we get started, let's cover a few conference details. If you have a question during the conference, we ask that you type in the question. Ms. Chen will do her best to answer the questions as we go along. If not, they will all be answered at the end of this conference. Also, if you are at your own computer station, a post-test survey will pop up at the end of the webinar. There will be 10 questions about the webinar and the personal information questions such as your name and email address that will enable me to send you your certificate. If you are not at your own computer, copy down the link that will be posted on the last slide of the presentation. Use the link at your own computer to complete the post-test. Certificates will be sent within 1 week after the closing of the test. Please complete the post-test by December 13th to receive your certificate. We are now ready to begin. Welcome, Ms. Chen and Ms. Rambach.
Thank you so much, Elaine. We are so pleased to be presenting to this group today because I know the Rosalind Carter Institute does a lot of great work, and particularly with caregivers. And caregiving tends to, it's actually a great passion of mine professionally. As a social worker here at the Fuqua Center, working with caregivers is one of the best parts of my job, and I get to do that in our clinic, our psychiatry clinic, as well as in some of the support groups that we host here at Wesley Woods. So thank you so much, Elaine, for inviting us to be here, and we're just so pleased to be presenting this topic, which I think will be helpful to anyone who comes in contact with older adults professionally or personally. So let me take a quick moment just to describe what the Fuqua Center is, and then we'll jump into the presentation. The Fuqua Center for Late Life Depression is a nonprofit organization that's housed within Emory University in Atlanta, Georgia. We were founded in 1999 after receiving an endowment from Mr. J.B. Fuqua. And Mr. Fuqua was a successful businessman and philanthropist in the Atlanta area. And the reason he got interested in late life depression is because he actually had a personal experience feeling depressed in his later years. Mr. Fuqua had never felt depressed before. He didn't talk about this issue with any of his friends or family, even any of his doctors, until he met with a psychiatrist here at Emory. And it was at that point that he was successfully treated, but he also realized how many older adults out there experience late life depression. Mr. Fuqua knew, knowing that he was a man of means and had access to resources, he was just really struck by the idea that there are a lot of folks out there who don't understand what it is to have a mental disorder later in life and don't have access to the kind of treatment that he eventually found. So he endowed the Fuqua Center for Late Life Depression with kind of two goals. One was to increase access to services, mental health services for older adults, particularly folks with lower income. And the second was to help break down the stigma that surrounds mental illness, particularly in late life. So a lot of what we do at the Fuqua Center has to do with advocacy, education, and outreach activities, and trainings and things like what we're doing today. So I think the topic that we're going to be talking about today is pretty helpful. What we're going to be presenting is 3 common conditions that are seen among older adults. And these conditions have kind of similar signs and symptoms. They're often mistaken for each other, but they're very common. So, you don't have to be a medical professional to recognize the signs and symptoms here, but becoming familiar with these conditions is really going to help you work with older adults and recognize some of those red flags that can come along with it. Now, I know that the audience today kind of works in lots of different environments, but my guess is that sometimes you are the ones who have contact with older adults and recognize those kinds of conditions first. So The goal of today's presentation is not to make you a clinician. We're not trying to get you to the point where you can treat any of these conditions necessarily. Our goal is just to help you recognize the signs and symptoms, recognize those red flags, and know what the next steps should be. So the presentation today is what we call the 3 Ds, depression, dementia, and delirium. These are 3 very common conditions seen among older adults, don't always get talked about. I know that this audience has had a lot of material on dementia already this year, so we're going to do a very quick overview of dementia. I'm not going to spend a lot of time on that, but we're going to focus more on depression and delirium. So the goal is to help you understand the signs and symptoms and the ways that we can differentiate between these 3 particular conditions. All right, so let's jump straight into depression. Depression is one of those terms that you hear a lot every day, and I think a lot of people have their own thoughts and opinions about it. There is a lot of stigma attached to depression still these days. Some people think of it as a moral failing, or I'm just, if I prayed harder, I wouldn't feel depressed, or if I was just a stronger person, I wouldn't feel depressed. But here at the Fuqua Center, we try to emphasize that depression is a medical condition just as much as diabetes or high cholesterol is a medical condition. And like diabetes or high cholesterol, you wouldn't expect to just leave it untreated and hope it goes away. So we really emphasize that depression is a physical disorder of the brain. We know that older adults are at higher risk for depression because depression is more common among people who have health problems. And as we get older, we're more and more likely to have chronic health problems. So it impacts quite a few people. 6.5 million people over the age of 65 are likely to experience depression at some point. And the figures kind of vary a little bit, but what we generally think of is about 1 in 10 older adults may experience depression at some time. Even though depression is very common, it is not a normal part of aging. That is something we try to emphasize here at the Fuqua Center all the time. Just because you're older, you may have experienced some losses or some health conditions does not mean that you should just accept depression as a part of your life. Again, it is a medical condition that can be treated, but what we know is that it is more common among older adults, and so that's something we should be looking for. We also know that people with memory issues, people with Alzheimer's, can be depressed too, and we're going to talk a little bit later about how we would possibly screen for that, but it's looking like the research is showing about 20% of people with Alzheimer's experience major depression. So let's go over some of the symptoms of major depression. And remember, major depression is kind of the most severe form of depression. Everyone can feel some depressive symptoms, and depression can kind of range from mild symptoms all the way to severe. Major depression is what we call clinical depression. So the main symptoms, you must have one or more of these 2 symptoms. You must have 1 or 2 of these symptoms, is depressed mood and or a lack of interest. Now, I think a lot of folks, when they think about depression, they think about sadness, somebody feeling really blue, really down. But what we know is that some people don't feel sad when they're depressed. What they might feel instead is a lack of interest, just kind of pulling away from the things that they usually spend their time doing, just not feeling up to any of their normal activities. This kind of lack of interest, sometimes it's called anhedonia, when you don't have any joy. You're not feeling any joy in the things you normally do. So those are the 2 main symptoms. You have to have 1 of those at least. Other symptoms, and I want you to kind of think about these so that later on when we talk about the other conditions, you can see how the symptoms overlap and how it can be confusing. A feeling of worthlessness or guilt, poor concentration or ability to make decisions, a lack of energy and tiredness, moving slowly or the opposite, becoming agitated and unable to settle, problems with sleep, and that might be problems falling asleep, staying asleep, sleeping too much, sleeping too little, changes in weight or appetite, and that could be eating too much, eating too little, having no appetite, and of course the most sort of severe symptom would be thoughts of death or suicidal ideation. We know that late life depression is a little bit different than depression in the general population. One of the things that we see is that some older adults don't talk about feeling sad. We've seen people in the clinic come in and say, well, I don't feel sad, but I'm so jumpy. I feel like jumping right out of my skin. I don't know what's wrong with me. Sometimes people call it irritability or having bad nerves. We know here in the South, sometimes it's not okay to say that you're depressed, but you can say you have bad nerves. So, some of what might be going on with older adults is it's a cultural difference in the way that they see depression, a different way of expressing how they feel. And also there's a lot of stigma attached to depression. It's hard to talk about it with just regular folks sometimes. Older adults we know that they also report more physical complaints. You might see those commercials for Cymbalta where there's like that circle and it's like sometimes depression hurts. What it's talking about is pain symptoms can come along with depression. That's because some of the pain neuropathways are shared in the brain and they overlap with the neuropathways that are affected by depression. And we also know that older adults tend to have more problems with cognition when they're depressed. And that's because of vascular changes, things that they've had go on in their life that affects them medically. And it kind of is an additive process where you add on depression and people tend to have more issues with thinking and with memory. We're happy to say that there's a lot of great screening tools for depression, and the one that I'm going to go through today is the Patient Health Questionnaire 9. There's also the Geriatric Depression Scale that's used. There's the Beck Inventory. There's lots and lots of depression screening tools out there. A question I often get in this presentation is, how do we screen for depression somebody who has dementia? They're usually poor reporters. How can we do that? There are scales out there. The Cornell Depression Scale for depression in dementia actually relies on a lot of input from family or from caregivers. So from people who are observing behavior and noticing things and can probably report a little bit better. But today we're going to go over the Patient Health Questionnaire. The reason why we like this questionnaire is that it's very straightforward. It's 9 questions. If you read the questions, you'll notice that they're very similar to the symptoms that are in the DSM. The list of symptoms that I just described for major depression are basically well represented here. So these are 9 questions that you could easily learn to do, even if you don't have a medical background. Anybody can be trained in using this tool. So what you're going to do is when you're working with someone who you suspect may be depressed is have them think about the last 2 weeks of their life, so really kind of more recently, and have them rate on this scale here how often these problems have bothered them. So, for example, Mr. John Q. Sample here, we're going to ask him, Mr. Sample, over the past 2 weeks, how much have you felt like you've had little interest or pleasure in doing things? And he would say, not at all, several days, more than half the days, or nearly every day. And you mark whichever category he chooses. And you notice that some of these categories are blue. That's going to be used in the scoring at the end of the screening. Anything that's in the blue boxes gets added up in that last box at the end where it says add columns and total. And on the back of the screening, I didn't include the grading scale here, but the number of symptoms that you have endorsed kind of shows whether you have mild depression symptoms, moderate, or severe. Also point out this last 10th question that they kind of snuck in here. If you checked off any of these problems, how difficult have these things made it for you to work, take care of things at home, or get along with other people? And so that's getting at how much has depression or these depressive symptoms impacted your life. All right. So why do we care about depression in older adults? I've talked about all these symptoms, and clearly it impacts your quality of life. But I did want to speak a little bit about suicide, because we know that depression is one of the main conditions that puts you at risk of suicide. And I'm sad to say that older adults are disproportionately likely to die by suicide. We know that there's about 12% of our U.S. population is made up of older adults, but 16% of suicides, deaths by suicide, are among older adults. So sorry, I said that in a little confusing way. Basically, 12% of people in our population make up 16% of deaths by suicide, and so that's a disproportionately represented group. So I always include this chart in my presentations because I think it is so striking. Let's look at that bright pink line, which represents white males, and we're looking at age on the x-axis, and we're looking at suicide rate on the y-axis. Follow this pink line along to your right, and you notice that it kind of plateaus for most of your life, but there's this sharp increase at age 65, and it is really very steep. We know that white males age 85 and over are at the highest risk of dying by suicide. And that is, I think really drives home the reason why we want to do screenings for depression and screening for suicide. And as people who work with older adults, we really need to be comfortable with these tools. The second line here, this kind of tan line underneath the pink line, is black males, and you see it's a little bit lower, and it kind of dips at age 85. That's largely because black males don't have as long of a lifespan, usually as white males. But there's definitely sort of an upward trend in later life as well. Some risk factors for suicide. One of the main risk factors for suicide is a mental health diagnosis, and that is particularly true of depression and substance abuse. Those two can also go together, hand in hand, increasing your risk factor for suicide. Age, as we know, people age 65 and over, as I just mentioned, are more likely to die by suicide. The presence of chronic illness or pain, I think that's kind of self-explanatory. If you're going through some major health stressors, it's going to put you at a higher risk of suicide. Previous attempts at suicide is a very important predictor of dying by suicide, as well as a family history, the recent loss of a loved one, and a history of impulsive behavior. Impulsive behavior is one of those things that affects how likely you are to make an actual suicide attempt. And so these are some of the main risk factors for suicide to just kind of keep in mind. Now, there are a lot of myths surrounding suicide and a lot of stigma as well. So I thought I'd take a little time just to talk about some of the myths that are common surrounding suicide. One of the ones I hear most often is talking about suicide may give someone the idea to kill themselves. And the fact is actually research shows it's the opposite. When interviewing people who have made a suicide attempt, most of what people say is if someone asks them directly about their suicidal feelings, it would lower their anxiety level. It actually is a relief to people to have somebody around them who clearly cares about them, has noticed that they're feeling bad or their behavior has changed. And actually asking somebody about suicidal ideation can be a deterrent to suicide. Another myth is once a person is seriously considering suicide, there's nothing you can do. And the fact is actually that most suicide crises are time limited. Usually it's a time when people are feeling desperate, like they have no other options, there's no escape. And so it's actually a very good time to intervene. Speaking with somebody and letting them know that there may be other options out there, that somebody cares about them, again, is a deterrent. It's a myth that somebody makes up their mind and that it cannot be swayed. The last myth I have here is people who talk about suicide don't actually attempt suicide. So this is kind of the opposite of what some of the previous myths. This is the idea that people who talk about killing themselves are using a cry for help. And maybe that's true sometimes, but the majority of people who kill themselves, 8 out of 10 people, actually give a definite warning of their suicidal intentions. We know that 75% of older adults who die by suicide actually saw a primary care physician sometime in the month before they killed themselves. So that idea just kind of really drives home to me that we should be screening people for depression. We should be screening them for suicide because they do come in contact with other professionals. Now, a lot of folks might be saying, well, how do I have a conversation with somebody about suicide? It is such a touchy subject. I don't want to insult them or make them think that I think they're in a terrible position. What we know from research and from working with people who have made suicide attempts is that asking somebody directly is really the best way of screening for suicide. Don't use euphemisms for suicide. You know, do you ever think about hurting yourself? Do you ever think about ending it all or passing away? You know, sometimes those phrases are confusing, and it's best to just kind of get it out there directly. Have you had thoughts of killing yourself? Have you had such thoughts before? Have you attempted suicide before? Anyone in your family died by suicide? Have you decided how you're going to kill yourself? Getting at some of these details, if you're working with someone who's really in a serious situation, can really help inform your next steps. And the other thing that I encourage people to do is just to take a moment and to reflect on your own values and beliefs about suicide. You know, we all get messages from church, from our family, from our different cultures about what suicide means, and we want to kind of be familiar with how we feel about it so that when we're working with someone who might be feeling suicidal, we can be aware of our own biases and our own views. The other thing I always like to say is don't try to, you know, take care of somebody who's feeling suicidal all on your own. You know, work as a team. Involve your supervisor, involve people's families if you can, medical professionals, clergy, because it can be stressful. You know, it's a stressful emergency situation, and it's important to feel like you have a team and that you're supported and that you can run things by somebody else and feel comfortable with the steps that you're taking. Screening for suicide is very important, but a full suicide evaluation should probably be done by a medical professional. That's going to be a very in-depth interview and assessment of all kinds of different medical and psychological issues. And then the last thing as professionals that I would always recommend is to document what's going on. That's for your own understanding. That's because sometimes when you're working with someone who's severely depressed or feeling suicidal, you forget kind of what happened in what order. So it's important to kind of remember that for yourself. But also so that, you know, you can reference it in the future and everyone on your team and in your agency or wherever you work kind of knows what's going on. So just a thought to document as you go. Now, we've talked about major depression, sort of severe situations like having a suicidal client or patient. What can we do about depression? There's actually many treatments for depression that are, you know, have different options. What research is showing us is the most effective method for treating depression is usually a combination of medication and talk therapy. Medication isn't for everybody. You know, if you're having mild symptoms or even moderate symptoms, maybe medication is not for you if you don't want to try it, but especially in severe cases of severe depression, medication and talk therapy is probably the way you want to go. There are also psychosocial interventions that can help sort of bolster all of these other interventions, increasing social engagement, getting people out of the house and out of isolation. Exercise actually has great impacts on both your physical health and your mental health. And for sort of the most treatment-resistant situations, there's electroconvulsive therapy. I won't go into great detail with that. I'll just say that we do provide electroconvulsive therapy here at Wesley Woods, and that for some people it is literally a lifesaver. So I won't go into great detail there. But again, in emergency situations, if you feel that somebody is at imminent risk of hurting himself or herself, or hurting somebody else, that is considered an emergency. They could be involuntarily hospitalized, which means hospitalized for a certain period of time against their will. That is a legal designation. And as health providers or service providers, what you would want to do in that situation is get somebody to an emergency room or call a mobile assessment team, which will come to the home, do an assessment, and kind of help you figure out whether the next step should be hospitalization or something else. All right. I like to include some scenarios in presentations just because it kind of helps you give some context to the stuff we're talking about. So I wrote this case based on, things we see a lot in the community and in our clinic. This is about a gentleman named Mr. Jones. You'll see him again in the presentation. Poor Mr. Jones. I've dragged him through all kinds of conditions. But we're gonna imagine that Mr. Jones is an older adult, and his case manager visits him in his apartment, and she finds him sitting in a dark room in the middle of the afternoon. And he says he hasn't eaten anything that day, but he doesn't feel very hungry. He used to go out every week to bingo, but he hasn't done that in over a month. And he says, I can't be bothered. And when he's asked about whether his daughter has come to visit him lately, he says, I don't want to call her all the time. She's going through a lot, and I'd just be a pain in her neck. So usually this is the time when I like to ask the audience, what are the symptoms that you're seeing? But in this format, I know it's a little bit hard. So in this next slide, I just underlined some of the symptoms that I think are being represented here. Mr. Jones is sitting in the dark in the middle of the afternoon. It doesn't seem like him. He hasn't eaten anything that day. He's not feeling hungry. So maybe his appetite is lower than it usually is. He hasn't gone to bingo for over a month, even though that's something he seemed to enjoy before because he used to go every week. So he's starting to pull back from some of the activities that he enjoyed. He says, I can't be bothered. And what does that kind of sound like? It doesn't sound like sadness, but it sort of sounds like losing interest in activities, which is another major symptom of depression. And this idea that, I don't want to bother my daughter, I'm just a pain in her neck, kind of gets at the idea that Mr. Jones is maybe feeling like he's a burden to his family. So he's definitely got some depressive symptoms here. And later in this presentation, Kathy and I are going to do a little dialogue so that you can hear about how you might start talking to somebody who's kind of in a similar situation. All right. So this next section on dementia, I'm going to go over very quickly because I know that you folks have had lots of information on dementia. I just kind of want you to see how it fits into these three conditions and how when you're trying to differentiate between them, we can oftentimes mistake symptoms of one for the other. So what is dementia? We know that dementia is a chronic and progressive loss of intellectual functions severe enough to interfere with everyday life. I think it was blocked out. We know that dementia is an umbrella term. I hope you like my umbrella. I made that for you. And dementia is a set of symptoms usually focused on memory loss, problems with your memory. And there are lots of different diseases that can cause you to have these symptoms. The number one disease that we all hear about the most is Alzheimer's disease. Sometimes it's used interchangeably with dementia, and that's because it makes up 60 to 80% of dementia diagnoses. The number two cause of dementia is vascular dementia, which is having a stroke or some kind of event that causes vascular damage. And there's also Parkinson's dementia, frontotemporal dementia, Lewy body dementia, some other more rare forms that I didn't put here. But what we're going to focus on mostly is Alzheimer's disease, and that's because it's sort of the big one that we see the most. When we think about symptoms of Alzheimer's, we know that it begins gradually. It's not that one day you are completely high functioning and the next day you're very confused and have memory issues. That's not how it works. The disease process is very gradual. It varies from person to person. So, here in the clinic we get a lot of questions from people like, what is it going to look like a year from now or 5 years from now? And the hard answer is it's difficult to predict. But the symptoms of Alzheimer's are pretty similar throughout, and that's going to be forgetting recent events while long-term memory is kind of intact, having difficulty performing familiar tasks, confusion. You might see personality and behavior changes, You might have impaired judgment, and you might have communication difficulties. Now, some of this sounds a little bit like depression, major depression, doesn't it? Especially the confusion, the difficulty making decisions or performing familiar tasks. You can see how these conditions could possibly be a little bit overlapping and a little confusing. Before I go on, I see that Peggy has asked a question: what causes frontotemporal dementia and Lewy body dementia? Frontotemporal dementia is a dementia that impacts the frontal lobe of your brain, and so you're going to see symptoms that impact usually your behavior. You'll sometimes see pretty severe mood changes and personality changes with frontotemporal dementia, and that's, that means that the proteins in the plaques and tangles that come with dementia are impacting the frontal lobe the most. Lewy body dementia, Lewy bodies are the type of protein that gather in the brain, and again, you're going to see a faster progression usually with that type of dementia. As a non-medical background person, I wish I could give you a better description of those dementias, but that's kind of...
Thank you. Please stand by.
We are experiencing some audio difficulties at this time. The slide presentation will continue and the audio will return.
Thank you. Please stand by.
Sensory deprivation is something that happens in hospitals or nursing homes sometimes when there's just 4 white walls around you, not a lot of stimulation, and all of a sudden your brain has a hard time figuring out what's going on, and it can throw you into something that we call hospital delirium. People who have hearing impairments who can't use their senses to really orient themselves can be more susceptible to delirium. And lastly, changes in environment. So when you're seeing a lot of very impaired people in a new environment, sometimes they can be thrown into delirium. We're running a little bit tight on time, so I'm going to skip through this slide. It's similar to what I was saying, that people who are hospitalized and have some impairments are more at risk for delirium. Why is delirium an emergency? Because there's actually a pretty high mortality rate in 1 year following delirium, and that's especially true among people who already have health problems, who are already frail. And the reason why it's an emergency is because there's oftentimes a medical reason causing the delirium, and we need to make sure that's immediately treated. You don't want somebody with a UTI or pneumonia to be suffering like that for a long time, because it can have long-lasting effects. How do you treat delirium? Usually what you want to do is get somebody seen by a primary care physician either that day or the next day. If that's not a possibility, it's perfectly fine to bring somebody to an emergency room. What I would suggest is don't send a person who's delirious to an emergency room on their own. And that's kind of common sense, but you would be shocked how often that happens. Send somebody who's delirious with a friend or a family member, somebody who can kind of advocate for them, explain to the doctor what they think is going on. Providing information is incredibly important because people get lost in emergency rooms, and if that person is there on their own or unable to kind of explain what's going on, the emergency room might just say, well, this person looks fine enough, their vitals are fine, all right, let's just send them home. Make sure you could call ahead to the ER and talk to the charge nurse, let her know that Mr. Jones is coming in, we think he has delirium, and they can give him a workup for that. And then the last thing is, because medication interactions can be a cause of delirium, it's really important to bring current medications if you can, so that the doctors and nurses can look at what's going on. All right, so just a quick review. Some of the red flags that come with delirium are sudden changes. This is happening over hours, days, or weeks, as opposed to dementia, which is more like months or years. If you think somebody is at risk of hurting themselves or hurting somebody else, that is also a red flag. That is a trip to the ER if that's necessary. Just keep those in mind. All right, so here's poor Mr. Jones. He's now delirious, and his daughter calls the case manager. She says, I'm worried because I think he has Alzheimer's. His memory has been getting worse. The case manager goes to see Mr. Jones in his apartment. There's a strong smell of urine. Mr. Jones is embarrassed, and he says he couldn't get to the bathroom in time last night, and he soiled the bed. And his daughter reports that he's been having accents for about 2 weeks. So this is one of those really common cases where you're working with an older adult, they have some memory issues, and all of a sudden their family thinks, oh, they've got Alzheimer's because the memory is so much worse. But you got to look at some of the other contextual factors. He's soiling his bed. This is going on for 2 weeks. It's sounding like he might have a UTI. He might have dementia too, but what you want to do is make sure that that UTI gets addressed, and then you can kind of see how well he's doing cognitively. This is just the summary page, kind of helping you remember how to tell the difference between these 3 different conditions: dementia, delirium, and depression. The onset is going to be different for each of these conditions. The treatments are going to be different. Dementia, unfortunately, we don't have any treatments that can reverse it. Delirium is usually reversible, which is why we want to get it treated right away. And depression is also reversible with treatment. Alertness is going to be another factor that usually helps you figure out whether this is delirium or something else. And I'm sorry, I should have taken out this last row here about the EEG, because I've spoken to some folks in our clinic, and I don't actually think we use an EEG anymore for dementia. But just keep in mind that folks with dementia are at higher risk for delirium, and that family history is very important when you're thinking about depression. All right. So the last chunk of this presentation is going to be about how do you take those next steps. Once you start seeing these symptoms, what do you do? What is the next step? So I called it helping an older adult get mental health resources. When you're talking with somebody who you think may have a mental health issue, it can be hard to start the conversation, but here are some sort of general tips that we all like to use, and this is pulled from Mental Health First Aid, which is an evidence-based practice that we actually teach here at the Fuqua Center. Listening non-judgmentally, this is going to help you working with any person, any older person at any time, because it allows you to understand what they're saying and thinking, and sends them the message that they're not being judged, that they can open up to you. You want to provide reassurance and information. Again, we may have some clinicians on the phone today, but we're not trying to make everybody a clinician. We're trying to just help you, help your clients get to the next step. So we want you to encourage professional help, encourage self-help, and we do want to assess for risk of suicide or harm. All right, so at this point, Kathy and I are going to do a quick dialogue of what it might be like working with an older adult who, in this case, you think may have some depression symptoms. And pardon our acting skills, we're amateurs. All right. So, hey, Kathy, it's so good to see you today. How have you been?
Oh, I'm okay. I'm hanging in there.
Are you? It's been a while since I last saw you, and Michelle told me that she hasn't seen you at the senior center in about 2 months. You used to go there every day, right?
Yeah, but I stopped going there a while ago. I'm just not interested in the center anymore. There's so many people there. They're always gossiping. I just can't be bothered with that. I'm so tired of all this.
What are you tired of?
Oh, I just don't have enough energy for all this anymore. Every day, I know the house needs to be cleaned. I need to go to the bank. I need to go here. I need to go there. My son keeps asking me for money. I just can't keep everything straight.
That sounds stressful. When you say you can't keep everything straight, are you talking about your memory?
Yeah, my memory's awful. I can't even sit down long enough to finish anything either.
Kathy, you look sad to me. How long have you been feeling like this?
I don't know, a while.
A while? Is that like a year or half a year?
Oh, no, not a whole year. I guess I just haven't been feeling myself since the summer, I think.
So that's been about 4 or 5 months. That's a pretty long time. Have you ever felt like this before?
No, I guess not.
Do you ever feel so bad that you have thoughts of killing yourself?
Oh, no. I know that's not God's plan for me. You think I'm crazy, don't you?
No, I don't think you're crazy at all, but I care about you, and I want to understand how you're feeling. Some of what you're describing to me sounds like they may be signs of depression.
Depression? What? I've never been depressed before. Honey, I'm 72. This is just how it goes when you get old.
Well, depression is pretty common. It happens to people of all ages. Some people have depression on and off their whole life, but some people never feel depressed until they're up in their years. And sometimes there's a medical reason that could be causing a change in your mood, like vitamin deficiency or problems with your hormones. When was the last time you saw a doctor?
Gosh, it's been at least a couple of years. Those doctors, they just want you to take medicine. I don't want any more medicine. I've taken enough already as it is.
Well, there are many good ways of treating depression that don't involve medicine, like talking to a counselor or getting on an exercise program. I think some of those things might help you feel better, but I would never try to force you to do something that you don't want to do. You know that, right?
Yeah, I know.
But I think it's important that we get you checked out. I want to make sure that there isn't something medical going on. Would it be okay if I call your doctor right now and help you make an appointment?
Yeah, that'd be okay.
Okay, and scene. So that was the dialogue that we put together, and it may or may not be completely realistic, but this is based on some of the interactions that I've had with patients in the clinic and other places. what we know is that, folks have their own conceptions about depression. Clearly, Kathy thought that, if you're depressed, you're crazy. And she also felt like, when I'm 72, and this is just how it is once you get later in life. And, as the person trying to help her get to where she needs to go the next step, what I really wanted to do was get her to see a primary care doctor so she could get checked out. And we could figure out whether her depression is being caused by something else, or if she requires some treatment. All right, so, if Kathy hadn't agreed to seeing a medical doctor at the end of this dialogue, what we probably would have said is just, think about it, and is it okay if I call you tomorrow? Because, sometimes it takes a little while for people to make decisions like that, and you don't want to be so pushy unless it is one of those severe situations and it's an emergency. All right, so a couple of sentences here that I sometimes find helpful when working with folks is, have you felt this way before? Was there something or someone that helped you? Was there something that you did that helped in the past? Would you be open to speaking to somebody about what's going on? So not moving straight into, you need treatment for your depression or for your memory issues right now, having some kind of dialogue is usually helpful. This is just a slide on the types of mental health services that you can expect to get in different settings. In an inpatient setting, you're probably going to be going there for assessment, stabilization, to get started on medications. We don't keep people in the hospital for long periods of time anymore, really. It's really there for crisis management. Outpatient settings like clinics or private practices are usually where you're going to get the majority of your mental health treatment. And then more and more now, there are people who are providing services in the home, and some of the folks on the line today may be some of those folks. But there are therapists that can go in the home sometimes, and there are sometimes doctors or nurses that can go and help with medication management. I do want to point you towards the Fuqua Center website because we do have a resource network that has mental health resources specific to older adults. We're still kind of fleshing it out, so some of these regions don't have as many resources as others, but that is available on our website. And then I wanted to have a little time, just a couple minutes left for some questions.
Well, thank you, ladies. Does anyone have any questions right now? And while we wait to see if anyone has anything to ask, I want to apologize on my end for the technical difficulties. I have a cordless phone, and it was about to die, and I went to switch, and somehow I got disconnected. So I do apologize.
That's all right. We recovered.
Yeah, we did. Live and learn. We're still waiting for some questions. And I have to say, too, Miss Chen and Miss Rambach, your acting skills were pretty well.
I appreciate that.
Thank you so much.
Thank you.
We won't leave our day jobs, though.
Yeah, no.
I almost believe Kathy was 72. Right there, Peggy has a question. Will we receive copies of the slide presentation? I'm glad you asked, Peggy. Yes, we do put the presentation on the Rosalind Carter Institute website. I'm not quite sure how it'll be this time since I was interrupted, but we will have the whole presentation there. It probably will not be until Monday. All right. Charlotte, what is the URL for the Fuqua Center? I believe that Jacqueline has just moved the slide.
Yeah, it's fuquacenter.org, so it's www.fuquacenter.org. And that's also where the resource network is, and you can also read information about the medical services that we provide at our clinic and the hospital and other educational events and things like that.
Okay, does anyone else have anything? We still have a few minutes to go in our hour.
I guess, I don't know if everyone would want to respond to this, but did some of this resonate? Like, have some of these conditions come up in your work? And I'm just curious whether anyone's worked with folks who they suspect might be one thing and it's turned out to be something else, whether it's delirium or depression.
I'm going to speak for them right now until they can type in some answers to that.
Sure.
That's one of the things that we're trying to do here at the Rosalind Carter Institute with these webinars is give the state employees and everyone different tools. So they may go in and think that they're going to talk to someone with dementia, and as they start doing their assessment, they realize that it's not. And with people like the Fuqua Center, they are giving them other tools. So
that's great.
All right, it seems that everyone has gotten quiet on us. I'm going to take that as no one has anything else to say.
Okay. Well, I really appreciate the attention that everybody's given us today. You know, this is my contact information with my direct phone line. If people have situations that they have questions about, we oftentimes talk with folks from the public to kind of help connect them as much as we can. And I know there are folks here from all over the state, so we'll do the best we can. And yeah, Elaine, thank you so much for your invitation today and the opportunity to work with you.
Yeah, and we appreciate your time. And I'm going to give it a second here for everyone to jot down your information. And remember, too, now, like I said, this will be on our website, so you can always go back and refer. And I'm going to advance the slide now so that you can take your post-test. So as soon as we close down here, and if you're not sitting at your own computer, please copy down the SurveyMonkey information there that you can take the test. And remember, you have through the 13th, and I will get your certificates out to you after that. And I'm going to stop the recording now, and thank you, everyone.
Thank you.
Thank you, guys.
Thank you. Please stand by.